thanking you all, as well as the association for inviting me here. It's a great place, my first visit to Colombia. And although I live in Canada, I'm originally from the south of India, similar to this place. And so, you feel like you're coming home. I was told to put a picture, and everybody was putting pictures of the beach or the exercise. This is what I do nowadays. This is like 2 weeks ago in near Toronto. I go for walks in the snow in the forest, and it's a good time. It's cold, but when you're outside, properly covered, it's a lot of fun. And just like you spend time on the beach, it's also fun to spend time in the snow. With that, these are my disclosures. What I'm going to talk about, I was advised to talk about treatment strategies or what we are doing in Toronto, but I'll try to adapt what we're doing and discuss many of the concepts that the previous speakers have talked about, Wilmer and Wilson. So we'll review the goals of treatment, identify strategies for better long-term management. And I'm not going to stick very much into the criteria. I'm not a very much a criteria person. I look at the overall what the patient wants. So we can talk about how we could do things. We'll talk about the goals of treatment and strategies for achieving remission. And when you talk about strategies, I think to achieve remission, you have to think about early diagnosis, to think about treating to target, and management of comorbidities. And Wilma had talked about all this, so I'll just reinforce that. So to start with goal of treatment. So what is the ideal goal of treatment? We have MDA, we talked about all the other DAPSA and criteria, but end of the day, what we'd like to do is achieve remission. It's difficult, but that should be our dream of getting it. And there are many reasons why achieving remission is difficult. And some of the reason is because it's the delay in diagnosis is a big factor. So when you think about remission, we, as many of you know, we have a cohort in Toronto. We see patients, we ask them to fill up questionnaires, we examine all the domains that was discussed, we do x-rays every 2 years. And then, so we can think about going beyond MDA or DAPSA because we have collected the data over the years. So what we did in this particular study was to look at, remission. And you can, what we did was to define remission as no tender swollen joint, no inflammatory back pain, no tender enthesial signs, with very little skin involvement, body surface area less than 1%. So patient's palm being 1%, less than that. And then the patient's visual analog score for pain was less than 15, global disease activity less than 20. This is borrowed from the MDA criteria, and the HAC less than 0.5, right? So we're looking at patient-reported outcomes and saying that from an inflammatory point of view, everything is absolutely normal. And we looked at patients from 2000 to 2015, and we had about 985 patients, of which slightly more than half were males. And so we looked at how many achieved this remission in this time period at least once, and that was just 18%. But what we're interested in doing is to achieve remission continuously. So we looked at least 2 consecutive visits, which means because our visits for the protocol is once a year, so 2 consecutive visits means it's about a 1-year period. And as you can see, it is less than 10%. Only 9% achieved remission. This is going beyond MDA and all that. So we have a lot more to go. When you look at MDA in our own cohort, it's about 50%. So 50% achieve MDA, which means there is some disease activity in many domains, 5 out of 7, as you all know. But when you go very strict, it's less than 10%. And what we like to achieve is really deep remission. So how do we do that? one approach is early diagnosis. So, as you know, as the more the patient has inflammatory disease, late diagnosis, more pain. Once you have had pain for some time, trying to get the patient to no pain or less than 15 out of the visual analog scale is going to be really difficult. There is central sensitization, fibromyalgia, which sets in with chronic pain. And so the earlier you can turn off pain, the better the long-term outcome would be, which means early diagnosis. So we looked at our own cohort, this was some time ago, and what we saw was that the longer the delay in the diagnosis, there was more progressive joint damage, more severe joint damage, and along with damage comes joint pain and poor function. Ours was a prospective study, but Dr. Fitzgerald, who's our president of GRAPPA, he did a study which was a retrospective analysis of their cohort, the database, and patients, even with a 6-month delay in diagnosis, there was a lot more erosions on X-ray and poor function when you measure by HAQ. So both studies emphasize that early diagnosis is really important. How good are we at doing early diagnosis? This is a study coming out of Mayo Clinic in Rochester, Minnesota. This is it's from the Rochester Epidemiology Project, and Paras Karmacharya, one new young member of GRAPPA, looked at delay in diagnosis. And he's going from 2000 to 2015. And as you can see, it's a big range of difference between the two, right? The diagnostic, the range is very high. But if you look at the line there has been no change in the delay in diagnosis. That means patients are not being diagnosed early. We still have a lot of work to do to improve the diagnosis. And how can we do that better? Earlier in the morning, we talked about education and getting awareness. And we have to screen patients because most of patients get psoriasis first. Screening patients for psoriasis, for psoriatic arthritis is a big step towards early diagnosis. And you have to educate the patients as well as dermatologists and primary care. And we can use screening questionnaires. We have developed a screening questionnaire in Toronto. There are other screening questionnaires, the PEST and the PACE. You can use one of them. Of course, you got to modify it for your own community, language, and Spanish in Argentina is probably different from Colombian Spanish, and so you might want to work on each country, each region need to modify it a little bit and see that it is similar. This particular questionnaire, which we developed in Toronto, when we tested in Toronto, it works really well. But Laura Coates and Philip Helleville has looked at this questionnaire in different places, and it doesn't really perform that well from a discrimination perspective. But if you look at the sensitivity, any questionnaire you use, the PACE, which is from Boston, or PEST from Leeds, or TOPAZ from Toronto, the sensitivity is quite high, 76%. And so I think for screening, it's pretty good. It's not specific. It's not a diagnostic tool. But if you use it for discrimination, the area under the curve is quite low, 0.5, 0.6, so it's like tossing a coin. But at least for an initial screen, it's good. The patient just fill it up. But also working with patient organizations, psoriasis patient organizations, say, by the way, if you have joint pain, get it evaluated. If you have joint swelling, get it evaluated. That will go a long way in making a diagnosis early. Now, other means of improving this diagnosis, one of the pushbacks we get when we try to say that you should be screening patients is that everybody's very busy. The rheumatologists are very busy. They said, we don't have time to see a lot of patients, many of them who will not have psoriatic arthritis. So there are other ways of doing it. We mentioned screening questionnaires. You could use physiotherapists who are trained to evaluate inflammatory arthritis as to help you in screening, and you can do ultrasound. And it's quite popular, and Dr. Eder, who's another member of GRAPPA, who is also in Toronto, she has done studies to look at what provides a better screening tool. And overall, all of them perform equally well. One of the problems, of course, is what is a diagnosis? We are basing our diagnosis on rheumatologist opinion. But you might argue that if the ultrasound shows inflammation, then maybe that should be the gold standard. But we have still not reached there. But if you look at this particular study that she published recently in Toronto, we see that each of these modalities performs similarly or relatively well, and only about less than 10% of these 233 patients had PSA, but about a quarter of them had possible PSA. So you might want to keep them on follow-up and work towards it. So the sensitivity is best for ultrasound, but the specificity was best for the questionnaire. So we still have a lot way to go to figure out how best to kind of screen these patients. Other option is to work with the dermatologist in a combined clinic. So I work with a dermatologist in Toronto, Dr. Rosen, and there is an organization called PPAC-MAN. Many of the members are members of GRAPPA, and our agenda is to promote combined clinics. And when you do combined clinics, you can make decisions quickly. You can choose the appropriate treatment. It's also an opportunity to teach the dermatologists about what we look for when you're thinking about psoriatic arthritis. It also helps in early diagnosis and also awareness. The patients know it, the residents and other trainees know it, and so it's a great education exercise. These combined clinics make it more efficient and patients love it. So that's one way of doing it. And through the combined clinics, you can also do more research. And for example, one of the questions that we have is that is treating the skin disease effectively with one of the biologics is going to prevent psoriatic arthritis? And there's a lot of debate on that. We're not so sure yet. Some studies do show that treating psoriasis will prevent psoriatic arthritis. And there is actually a clinical trial going on with randomized to guselkumab and placebo for a short period to see if this prevents or at least delays psoriatic arthritis. So, and like I mentioned earlier, early diagnosis or even preventing disease is the best way to achieve remission, right? If you don't have the disease in the first place, then it's going to make a huge impact. There's not going to be pain or loss of function. So some of these trials which are beginning to be done in prevention is probably going to help us achieve that goal of no PSA. But it's a long way to go, and working with the dermatologist, you can actually recruit the right patients for these kind of trials. The other thing is treating to target. And you heard two of the talks talking about treating to target. And important thing is to choose a target that works for you. You could use the MDA or the DAPSA or the CPDI. We recommend the DAPSA because it also includes the skin. And the important thing is to keep monitoring it. And if you're not in DAPSA, if you're not at your target, then try to modify it. Minimal disease activity, you heard about it. It is 5 of 7 criteria. And GRAPPA recommends that you achieve the target you monitor the patients to achieve target to get the best outcomes. And the GRAPPA guidelines recommendations that are published recently explains that. But I'll focus on, rather than the treatments, about the overarching principles. Some of the important things are, Wilma talked about all the domains. So you have to evaluate all the domains and try to achieve the least disease activity in that domain. That will help you get the treatment. You should consider all domains, and so that with the drug that you treat, hopefully will help all the domains. Important thing is comorbidities, because I'll show you that how effect of comorbidities on treatment and achieving remission is important. And shared decision making. You have to sit down with the patient to decide what is best. Otherwise, you're not going to achieve the goal together, because it's always about discussion and convincing the patient that it's important. So what we do in our clinic, this is all domains. Define the treatment for target. It may be MDA, which is not as good as the remission that I mentioned, but it's still good, prevents joint damage. Some people argue that, it's too much, I can't do this in the clinic. I just want to remind everybody that 3 of the things that is in the MDA is by the patient. So as the patient is waiting for you, it takes them 2 minutes to fill up that. And on our side, we need to look at as we're seeing patients, we have to look at the skin and joints, and the enthesial points, right? So use the leads or another enthesial index to do that. And so it's not that much of a burden on us. You identify the active domains, and then you discuss with the patients,
if the patient is not an MDA and is otherwise not doing well, what are the pros and cons of changing treatment? If you escalate treatment, there's always a discussion about side effects, and you have to get that shared decision making with the after looking at the patient's preference. So it's not just escalating therapy if MDA is not done. It's a process that and I think that discussion with the patient is the biggest strategy, rather than checking things out on a check form that yes, MDA, no, or for that matter, any of the classification criteria. We have to look at each domains, and I won't spend time here because you all know the 7 domains, but important to also think about other manifestations like inflammatory bowel disease and uveitis, which would influence your treatment. Because some of the drugs, as you know, might worsen one manifestation, and so that has to be taken into account. And Uri Sher and Chris Richland talked about how it's time, because we are all having patients who are not responding to biologic therapy, to move forward. And this review or a perspective in arthritis rheumatology talked about how we can do combination therapies to achieve this goal. So we are not there yet. Studies are ongoing. We have currently a combination therapy combining guselkumab and golimumab in patients who have failed one biologic. So these kind of trials are going to come where you're going to start combining biologics, because now you have reached a point where one biologic is not helping, or some things are good, some are worse. The joints are better, the skin is worse, or IBD, etc. So that it's a work in progress. But now we have become, after 20 years of having biologics, single, your monotherapy with biologics, now we are thinking about combination therapy with these agents. And then comorbidities. Managing comorbidities is integral to managing psoriatic arthritis, because it's more difficult to achieve remission or low disease active states when there is active comorbidities. Important one is obesity. Lots of our patients with psoriasis are obese, and more obese the patient, if you have psoriasis with obesity is a big factor for developing psoriatic arthritis, and they're also resistant to treatment. And when you have obesity, you are less likely to achieve minimal disease activity, and this is data from our cohort. And there have been studies where they have tried to reduce weight to see if that improves, mainly strict diets, and you can see that weight does go down with diet therapy. And this is a study from the Nordic, from Denmark, and both the weight came down and the DAPSA score also came down. So we have to counsel our patients about weight reduction, because that really helps in achieving remission or reduced disease activity. And sometimes it is amazing when somebody who's quite obese loses weight, that they no longer need the therapy that they were on. Remissions off drug has occurred. Not very often. I have 1 or 2 patients, but it's very gratifying when you see that. And it's also, it's not just the arthritis in skin, but cardiovascular disease and diabetes, etc. We looked at our own cohort. This is the same study that I showed in the first, and looked at what are the predictors of achieving this kind of strict remission, which happens only, by the way, in less than 10%. And what did we find? People on biologic therapy, the small molecules like tofacitinib and upadacitinib probably also would be associated, but we don't have enough patients on those drugs yet to make that prediction. But biologic therapy and not being obese were the 2 best predictors. So weight is really important in having a strategy to manage that. Is quite important with primary care or diet, with diet and exercise. The other thing, of course, is depression and anxiety. This particular study, which I did with a fellow from Ecuador, Antonio Wong, showed that if you have depression, if you have depression and anxiety, whatever the definition of that was, is consistently associated with a lack of achieving minimal disease activity. So it's a big challenge. We don't know how to deal with it. We have to help primary care and then also help of psychiatrists to achieve this. And but at least recognizing that is important, and it's very important for the patient too. So what I've not given you a strategy that will help you achieve remission in all your patients, but I just wanted to make it sure that these kind of strategies have to be tailored to your own practice, but it's important to consider how you can diagnose patients early, because that's going to be a big factor in achieving remission. how you should treat to target, and choose your own target that works for you. Of course, you have to consult with your patients, and it's a shared decision that you have to make. And comorbidities are really important. You have to work with your family physicians, primary care practitioners, ophthalmologists, dermatologists, depending on what manifestations the patients have, and work towards reducing weight and improving mental health, which will make a big impact on achieving remission from the patient's perspective. And with that, to summarize, remission is the ideal goal for PSA, but may be difficult to achieve, and the definitions vary. It can be achieved by early diagnosis, treating to target, and management of comorbidities. With that, I'll stop here. This is our research group here. It's a picture pre-pandemic. We'll have our meeting soon, and we will get a new picture. But I just wanted to show that in this particular group, we have my mentor, Dr. Gladman, who is in the center there, but also Dr. Rosen, who's a dermatologist. We have in our research program statisticians, patients, and many research members who look at various aspects of the disease. And we'd really have to have a team like this to move the agenda for psoriatic arthritis forward. With that, I'll thank you all and happy to take any questions.